Hello, welcome. I'm Dr. Lewis Hassel, Professor of Pathology at the University of Oklahoma, and thanks for joining me today as we consider some additional digital slides and the appropriate sign out for these cases. Our topic today comes from the realm of GI pathology. It's a patient who has a history of Crohn's disease, and in the course of her evaluation, underwent a repeat endoscopy that included an upper endoscopy to look for signs and symptoms involving that tract because she had some variable and vague symptoms. And lo and behold, at the time of endoscopy, an additional lesion was noted that seemed a little bit unusual and not necessarily like the typical appearance of Crohn's disease. So they took a biopsy, and this is kind of what the surface looked like when they were in there endoscopically. Notice you have these very punctate, protruding, whitish, thin-walled cystic spaces, a little bit of glistening fluid perhaps in them, as you can see here. And later, after the biopsy, this was resected, and I'll show you the gross photograph here, which has this sort of dilated spaces turned into sort of reddish brown, very spongy appearing lesion without significant tissue mass to it, just a slight distortion of the architecture. So on the biopsies, we saw this appearance here, and we'll go into higher magnification here, and you'll see that architecturally these look fairly unremarkable at low magnification. But as we look around a little bit, you'll begin to see that there's some subtle abnormalities here in some of these. And particularly this fragment here has a very nice demonstration of this. As you see these clear spaces here extending up into the mucosa with very thin, delicate walls and sort of a dilated luminal type of appearance. So, we see dilated lacteals from time to time in the small bowel, often associated with various digestive states and so forth. But this seemed to be a little bit more extensive. And we'll show you another area here, just so you get an appreciation on the biopsy for the kind of thing we're dealing with. So here you can see again these very dilated, thin-walled vascular spaces, not filled with red cells, but just with this pale eosinophilic fluid that would characterize lymphangioma. And obviously here extending a little bit towards the maybe muscularis mucosa and the submucosa deep to it. So a resection was done, and you can see here that again we have this quite a busy appearance here in the submucosa, and quite dilated thin-walled tissue with really not much in the way of substantive tissue associated with it. A little bit of variability in the walls here, as you can see. Some are a little bit thicker than others. So there's maybe a little bit of that type of variability. And then let's look at another section here. It shows it nicely how it extends up into the mucosa. I think we'll see that right here. You can see here are our dilated mucosal vessels. And here we see involvement of the muscularis with extension here into the mucosa and so forth. A similar case was resected and located in our teaching files. And here you see a more full thickness section. And this also shows the same pattern of a prominent submucosal lesion with extension up into the smooth muscle of the muscularis mucosa, and then further out into the mucosa with variable amounts of dilated villi and dilated thin-walled vessels. So The diagnosis here is not particularly challenging. It's just unusual to see this because this is an uncommon primary lesion in the small bowel. We see them with some frequency in other locations in the body, in the head and neck region, of course, and more frequently in younger patients in that environment. But in the small bowel, they tend to be a little bit older patients and not associated with some of those syndromes that are more prevalent in younger children. In fact, a fairly interesting study looking at a case series over 10 years of over about 15 of these lesions found that most of them were asymptomatic and had only been discovered incidentally, which perhaps may reflect what happened in our case. They may be associated with some degree of pain, and a few patients have a degree of bleeding associated as a symptom, maybe even melena. Because these will tend to be usually small bowel lesions more frequently. They were identifiable on endoscopy because most of them do have a surface lesion or involvement to some degree, and they may extend deep enough to go actually into the mesentery as well. Because of that, this propensity of the bleeding and so forth, resection is still preferred, although certainly you want to do that within the realms of capabilities that you have in your institution and without incurring other complications, hopefully. So our final sign-out diagnosis today is lymphangioma of small bowel. As bonus material, I've included in the link below to the digital slides, which you're free to study on your own, a few additional examples further illustrating this in various locations. So you can study those at your leisure. So I hope you enjoyed that. Thanks so much for joining me. It's always a pleasure to have you take a look at what we are thinking about and coming across in our practice. If you have questions, please don't hesitate to reach out or make a comment. And of course, we do hope you'll hit that subscribe button and give us a like if this was helpful or something that you found useful that you think others should enjoy as well. So until next time, thanks so much for joining me.